Hello, everyone, and welcome to IBD Life's fourth educational seminar series. Today's session on IBD at Pediatric Transitioning to Adulthood will be moderated by Dr. Joel Bauer, Lyfeulb's Chairman of IBD Education. I'm Jamie Hates. I'm the Director of Partnerships at Lyfeulb, and before I let Dr. Bauer take it away, I'd like to remind everyone that Lyfeulb is hosting an innovation challenge in IBD in collaboration with Bristol Myers Squibb, and we're currently in the application phase. So if you're an entrepreneur or if you know of anyone who should apply, please do let us know and check us out on lyfeulb.com. Thank you.
Hi, I'm Joel Bauer, and I'm the Director of Education, IBD for Lyfeulb and IB Life. So we have three panelists who are all pediatric gastroenterologists from different institutions in the New York area. We have Joseph Picoraro, who's from Columbia, Kimberly Chen, who's from Weill Cornell, and Marla Dubinsky, who's from Sinai. So I'm just going to ask one question, and it may be different in different institutions. When does a pediatric patient with IBD transition to an adult patient, and do you then switch off the care to an adult gastroenterologist? Do you want to handle that, Joseph?
Yes, I think my answer will probably be similar to others here. It all depends. There is no strict guidelines on when this occurs, and it depends on the patient. So our practice is that transfer of care, because transition is a process that takes several years, is going to occur when the patient is ready and the conditions are the best for the patient. And so we work closely to see what's going to work out best. For some of our patients, if they're staying in New York, that transfer might happen earlier because we're working closely with our adult colleagues in the area. If they're, for example, going away during a transition where they might be going to college, another part of the country, then they might stick with us, and we try to coordinate the care locally with the college they're going to, and that transfer to an adult provider might occur a little bit later. So it all depends on the circumstances of the individual, and it's a process it's individualized through those stages.
Dr. Chen, is that similar at Weill? You don't have any institutional guidelines?
Yes, here at Cornell, we also don't have any strict guidelines. We really leave it up to the primary pediatric GI, along with the patient and the family, to decide when is the appropriate time for them to transfer over to an adult GI provider. I think it depends on each individual's, readiness, developmental stages, maturity, also what else is going on in their lives too. Sometimes, going off to college at 18 is already a daunting process. So maybe that's not the right, time for them. So we really try to individualize the experience for our patients and their families and determine the best time to transfer together.
Marla, is that what you do at Sinai too?
Yeah, a couple of sort of things to add. A lot of it is about how confident the patient is at being able to self-manage, right? And there's some key things they have to know how to do. They have to know the address of where the new gastroenterologist is located. They have to know the phone number. They have to make a follow-up visit. They have to know how to call their insurance company. They have to know how to do refills. So it's on us, truth be told, as pediatric gastroenterologists, to arm our patients with that information. When you have that information, and that may not happen, they turn 18, it doesn't mean that all of a sudden everything changes, right? It's a process, as Joe had noted. So I think it's on us as peds, as well as the parents, need to start empowering the patient with these skills. When the skills have been reached, so it's more about the timing of when they've acquired the skills as opposed to an age. And we know that the more resilient, which means the more self-confidence someone has in their ability to self-manage, more than age, is a secret to success of that transfer, because the adult gastroenterologist expects that the patient already knows how to do these things. And there's this added sort of transfer tipping point whereby the adult gastroenterologist assumes that the patient knows how to do this and the patient never did it. It's really where the wheels, where everything falls apart. So I think for me, it's about skills building. And then once they have those skills, you can adequately feel confident about the transfer.
So I'm curious about this myself. So each of you, what's the age range of the patients that you treat, Joe?
Well, so from birth through personally
No, I'm talking about
probably,
with IBD, with IBD.
oh, yeah, well,
Because I know that I rarely operated, and I was operating on many children, but I rarely operated on someone. I think the earliest one was like 8 years old, so with Crohn's or colitis. So
yeah.
what is the age range of IBD patients would you say that you treat?
Well, we do have some cases of very early onset inflammatory bowel disease that will present in the first few years of life. So it definitely is from birth where this disease may be going on. And we do have 4, 5, 6, 7-year-olds that very commonly present more and more so. So it definitely is early on. But through the other end, could be 22, 23, kind of depends. So when they're ready. To make that transition.
So it's rare that you're treating someone who's 30, for example, even though they may have been a patient of yours from the time they're 10.
Me personally, yes, that's right. That's right.
All right. I have a question that I've often pondered the answer to. Marla, is there difference, not the emotional differences, but is there in the medications that you use to treat, let's say, Crohn's disease? Are there differences in what you use to treat children versus adults?
I mean, historically, pediatric gastroenterologists tend to be a little bit more timid around the use of early use of biologics. That has changed. I don't think
maybe cautious would be a better word than timid.
I'm having done this for 25 years. Okay, if you want to be politically correct, what I would say is that we probably underutilize effective therapy just for fear of or parental fears or concerns around safety. Because remember, in pediatric, we only have 2 biologics approved formally, Humira and Remicade. That's it. Yet the average time to approval for Remicade was 8 years from the adult approval. If we had waited 8 years to actually use an approved therapy, there have been a lot more children gone to the operating room. So we know that we need to start being a little bit more assertive with the therapies, even when they're off label. Look, Entyvio was approved in 2014. We are now approaching 9 years. That drug has not even finished a phase 3 trial. We don't have time, right? We've got a window of puberty development. So if anything, what I would say in pediatrics, you need to integrate steroids sparing strategies earlier than adults because of that growth effect of chronic inflammation, malnutrition, and steroids, for example. So if anything, we should be using them more, which we are probably actually than adults, to be fair, closer to diagnosis. And second of all, the dosing that is approved for adults is often underdosed in pediatrics because children tend to clear these drugs almost 40% faster. So the problem is we don't have the right dose approved and we don't have the drug approved. It's very complicated for pediatrics, which is why I think we implement a lot of therapeutic drug monitoring and ways for us to be much more sort of in tune with the amount of drug our patients have in pediatrics, more than even we do in the adult setting.
So Kimberly, does the fact that these drugs, good drugs like Entyvio, are not FDA approved, does that modify your ability to prescribe them? Or do you prescribe them anyway? Off label, I guess.
Yeah, I mean, unfortunately, they are not available officially to our patients, but if a patient needs it, we find a way to get it for our patient because that is providing the best care for our patients. And we certainly are seeing many IBD specialists doing this as well. You know, if our patient needs it, it is really the way that we have to treat our patients.
A question that I had has to do with maturation, and when someone pre-puberty, let's say, has this disease or any chronic disease, whether it's kidney disease, heart disease, there's often a growth issue, which is not part of anything that I paid attention to in the adult population, or had to pay attention to it. Joe, how does that affect you? Is there more urgency if somebody's epiphyses haven't fused and the kid is under height and underweight? and even though their symptoms are not terrible?
Yeah, I would say, as pediatric subspecialists, we tend to be both strong advocates and always in a state of urgency, because time is always of the essence. As pediatricians, growth is paramount throughout, and so that's sort of in the context of everything that we're focusing on. So it's built into how we approach all of children's health. And so for us, there's always urgency there, right? Because the clock is ticking. And I would say that fortunately, I think our community has learned that in a lot of ways, we move faster sometimes than the adult IBD specialists now to take care of kids. Not only because we know that disease can be a little bit more aggressive, but we know we have to be, right? And that engenders this advocacy that we have to do to fight with insurance companies and advocate for the drugs earlier on, even if they're not approved. Because if we can see that they're safe and effective, we're going to make sure that the children get them when they need them.
So Kimberly, have you actually treated a child, let's say pre-puberty, more aggressively, even though their symptoms are not terrible, but they're way down on the curve of height and weight?
Yeah, we definitely take that into consideration. It's not like a minor consideration, it's a major consideration, because like Dr. Pecoraro says, and I'm sure Dr. Dubinsky also feels the same way, growth is paramount to these patients. And we want to ensure that getting early aggressive treatments that get the disease under control sooner will allow these patients to be able to make up for their losses and then therefore be able to thrive. The earlier, the better.
Feel the same way, Marla?
Yeah, I'd say that we have to recognize that growth failure alone is not an infrequent presentation for Crohn's disease, not ulcerative colitis, by the way, because we're talking about diseases that could impact the proximal small intestine where all the food is absorbed. There would be losses. And so they often have a journey where they'll go to the endocrinologist, or the pediatricians said, you know what, let's just height you again in 6 months, see if you continue to be flat. Maybe it's constitutional growth delay. They go to a endocrinologist who says, I'll run your celiac panel. Whoops, someone noticed you had anemia. I mean, it's a long and winding road for some of them. So by the time they get to us, there's an urgency because they could be 2 to 3 years behind in their growth. I've seen parents who say it's funny, at the elementary school graduation, they were at the top end, they line them up by height. And then I noted at middle school graduation that they're at the other end. And I missed my well visit last year. So whoops, my child may not have had a height. It's not an uncommon scenario. And we have to realize that that's a pretty significant extra intestinal manifestation of systemic inflammation. And the growth plates are sort of filled with all these cytokines. That means we have to go out and sort of vacuum out or Pac-Man out all of this inflammation sitting in the growth plate, because kids develop growth hormone resistance. They're not deficient 99% of the time. They're resistant because their growth plates are filled with all of this inflammation, and the growth hormone's just trying to get there and it can't. So that's why we local therapies that coat the inner lining of the intestine will have zero impact on growth, which is why we need to use systemic, typically biologic-based therapies, so that it could get to the growth plate and sort of turn on the system and eliminate this growth hormone resistance. That's an important concept that isn't discussed enough as to why, even if your child feels fantastic, it's hard to have a discussion with families, I'll be honest, because they just came to attention because of height. It wasn't because they were missing school because of pain or they weren't in the bathroom all day. It's not an infrequent, difficult discussion, but I think once you sort of map it out as to the fact that it's where it is in the bowel renders it not classic presentation for Crohn's or ulcerative colitis, the families understand that this is this growth effect. And I'll tell you, the one thing the child wants, they would deal with going to the bathroom. They'll deal with some pain, but being the shortest in their class or really falling behind when all their friends are actually going through puberty, that is a massive impact on quality of life of these kids. That's why we need to be, as everyone's been discussing, much more assertive about our approach to growth failure. And we don't have to deal with that with 18-year-olds when the growth plate is closed, in theory, right? This is a very specific pediatric type of problem.
All right, so I want to just switch here from these sort of chronic issues to certain fulminant disease, okay? And I guess we'll take ulcerative colitis because I wonder what is your first line therapy for a person that you've been treating with anti-TNFs who suddenly is failing the anti-TNFs or the anti-integrins, and all of a sudden, I'm not saying they have megacolon, but they come in and they are really sick. They're bleeding, they're anemic, they're distended, and they're having 20 bowel movements a day, and they require hospitalization. Okay, what is your go-to medication in the pediatric group like that, Joe?
Well, if this is a patient that's already been through anti-TNF and anti-integrin, being hospitalized, I can't say that we have a go-to at this point in pediatrics. At least it's not evidence-based with clear safety data on our side. There are circumstances in which anti-TNF therapy maybe hasn't been optimized in a way that we might be able to capture them. So that certainly needs to be looked at closely. Depending on the center and what their practices are, that's an important consideration when they're coming in that setting. The role of steroids are going to be important to consider because that might help sort of guide the ship, but we want to be careful about it. The scenario that you're describing, though, of course, we need to have surgery involved right away in order to anticipate that this may be the direction that we go. The medical therapies that are available to us, though, that certainly have more experience in adults and we're gaining more understanding of it in children, would be medications like tofacitinib, ustekinumab, also may have a role, but again, in children, we're limited to case series and experience that's somewhat limited. We don't have a ton of data to help us out with a go-to in those settings.
Well, I know that years ago in the adult population, we were doing a study on cyclosporin, and we used to get, and in the study group, they had to be a failure with max dose IV steroids in either our hospital or in the transferring hospital. And we had actually very good results with, let's say, colon salvage. In other words, these people came in and would have ordinarily been operated on within 24 hours. And many of them, I can't remember the number, but the paper the president and I wrote was that I think we had something like a 75% initial salvage rate. That's not to say what happened to them in the next 10 years, but they didn't lose their colon. Do you use cyclosporin or anything like that anymore?
So,
and by the way, we had very few side effects. We had very few adverse events from the cyclosporin.
Yeah, in children, tacrolimus has been used. We don't use it too much, actually. There comes a point when we want to make sure that at the same time that we're trying to use medical approaches, we're also optimizing for the potential of surgery, right? And so when we're making these decisions, we need to keep that in mind, because sometimes if we spend a lot of time trying to do medical management, we end up in a place where the surgery is not going to have as good outcomes. And so we need to keep those together as we're going through these day-to-day decisions, sometimes even, hour-by-hour decisions with our surgical colleagues.
I mean, I'll just state, for all of us, we're not in the business of saving colons just as a totality. I mean, if a patient comes in, they had good REMI levels, they're steroid refractory, C. diff negative, CMV negative, white count up, albumin 1.9, maybe even a slight left shift, that patient's going to the OR. We're not messing around with cyclone typically, and we're not also throwing on a JAK inhibitor. Although if they don't have any of that and they're just really refractory to TNF, I'll tell you, the second line biologics, ustekinumab and Entyvio, for example, don't work typically in a strong TNF failure quick enough in a patient who's in the hospital failing steroids. So our go-to, although as Joe noted, the data is not, this is very off-label use, is that pretty well if the patient is not in a toxic or fulminant or should be in the OR kind of setting, then we have switched cyclo and Prograf for Rinvoq. So pretty well, we've taken the JAK inhibitors that you'll know within 1 to 3 days whether this patient is actually responding. If you can get it, it's not on formulary in any hospital. Typically, you have to get it as an outpatient. It's not easy. It's very off-label, and also for pediatrics, we need to get the patient better, and we don't have a lot of options. So I think all of us would say if they're sick, they need to go to the OR. And if they could be managed with a second drug, it would be less a biologic, it would be a JAK inhibitor, either Xeljanz or Rinvoq, if we can get our hands on it. And that's what typically I think most of us are moving towards, away from the sort of cycloprograph world and moving into a JAK inhibitor world for acute severe UC. We need more data, but that's sort of where we are. We know we never have data anyways. We need more data for everything, but particularly in this particular scenario, we need much more data.
Oh, Kimberly, when do you have a sick patient, been on managing on whatever you have them on, and then suddenly gets fulminant and has to be hospitalized? At what point do you say you need surgery to either the child or the parents? And often it's a very difficult conversation with the parents. And I agree totally with you, Marla, that you can't wait. If by your standards, that colon has to come out, you just do a subtotal colectomy, you can do another operation 3 months later, and the results are really miraculous, rather than winding up with a perforated colon where the morbidity goes up, skyrockets. So what? Tell me how you focus that conversation to, let's say, the parents of a 13-year-old.
Mm-hmm. Yeah, unfortunately, I think oftentimes surgery is used as a last-minute resort, a last-minute resort kind of approach. But really, as both the others have mentioned, it really should be incorporated early. It is something that could really obviously be life-saving and a treatment that is very effective. So frankly, if we see a patient that's coming into the ER or we're hospitalizing that is having severe disease, we'll actually have the surgeon come in early on. We will let them know that we're bringing them in. We're not necessarily saying that surgery may happen, but we like to bring them in early because it's better to know your surgeon and their team early on, rather than in a last minute emergency situation in the middle of the night or who knows, And in that, by approaching them, and of course we give our explanation of why we think it's important, but I think that by bringing them in early, let the parents kind of familiarize themselves with the surgeon and their team, understand the reasons why we're leading to this direction in an early manner, they get a little more open to the idea, and it's not as scary as, let's say, a really emergent situation. And in that manner, we also can prepare them. We bring our ostomy nurse in early, give them a whole discussion on everything that, might occur and, that the surgery might entail. So that's how we approach it. I don't know how the others.
I would endorse that, because even though many years have passed, often, especially to parents, the surgeons are thought of as gunslingers and quick to operate and so on. And it was much easier for me to approach that patient if the gastroenterologist, adult or pediatric, had that conversation with the parents first. Because first of all, you're the ones who have the rapport, maybe for 6 years with that patient and that family, as opposed to a surgeon in a scrub suit coming into the room. So that was always made things a lot easier for me, and I'm sure the current group of surgeons. We're not going to get into when you can do a J pouch in one stage and so on, but let's arbitrarily say that this person is sick enough that you think that you and the surgeon will only do a subtotal colectomy, either because of the nutritional status of the patient or other local factors. You just reassure the patient that they will be fine once they get over this hurdle. Is that how you do that?
So Yeah, so, interestingly, just a reminder that the younger the patient is, the more, truth be told, uncertainty as to whether or not it's truly ulcerative colitis or is this a Crohn's-like phenomena, right? So that does add a layer in peds where we have to always be honest and transparent about the fact that the first step is we need to get the beast out, which is a subtotal colectomy. That is what's causing, all of the illness. And then we can discuss based on the pathology, based on other factors, whether or not truthfully this is a Crohn's-like colitis or is this a true ulcerative colitis? Is there an ileorectal? Are we going to do a J pouch? There's a lot that then goes in, but the most important thing we need to focus with families is their child is sick, right? And we need to be able, we will deal with next steps after we get the colon out and leave the rectum in place, and then we can have some high level discussions. So I think the most important message really is that their child needs to get better, and they will feel better within an hour of waking up from the surgery. That's how severe the pain was. That's how systemic the inflammation was. And I think we need to do it step by step. I don't like to get ahead of myself and say, oh, in 3 months, we're going to do the second stage. Then 3 months later, we're going to do the third stage. Like, we need to be realistic and logical in our conversations with our patients.
All right.
And their families, actually.
Do you ever get into conversation, particularly in young women, about fertility and fecundity? Kimberly? After J-pouch? Before J-pouch?
To be honest, I have not had many patients who discuss a lot about pregnancy and J-pouch, but it can affect fertility. And so it is something that, should be considered. Do my other colleagues have more patients that have been more of this age and also wanting to get pregnant?
Yeah, since that's
like
the other part of my life is my fertility and pregnancy clinic. I could say that I go in, to be fair, Kim, I'll say to the family, because it's, that's what there's a lot of families who would have read about that, right? Because on the internet, there's a lot of myths around the fact that don't do a J pouch because it's going to result in.
What do you tell them, Marla? It is a discussion. I mean, I used to have those discussions all the time. There was a Swedish study that came out early on that showed that people who had J pouches, that their fecundity, which is slightly different than fertility, is their ability to get pregnant, is 6 times less than a person with ulcerative colitis who didn't have that operation.
Yeah.
We
remember,
as surgeons, what we would start to do was do in a woman who wanted more children, to do a subtotal colectomy, wait until they were finished having children, and then if they still wanted to have a J pouch, do the J pouch at that point. And I had at least half a dozen women who chose to go that route. So but we saw a lot of patients,
Yes, I agree. And remember, that's from open surgeries. To be 100% transparent, we don't have really great data in the era of laparoscopic J pouches. So and remember, like you said, there's a reason. It's because the pelvic dissection, which is the actual creation of the J pouch, is where the plumbing could get clogged, in a sense, is that you can get adhesions around the fallopian tubes. And really, the uterus is fine. Women can carry as many babies as they want. It just may not happen naturally. So that's a conversation that I do explain as to where the data came from. And right now we're starting a prospective fertility registry in the era of laparoscopic surgery to be able to hopefully tell women, get all 3 stages. In the era of laparoscopic, we're really not seeing anything that we saw in the face of open surgery. And I'm hoping that will put a exclamation mark in the conversations that we have moving forward. So we'll wait for that data. But I think I'm very honest that a 10-year-old, even though the mom may be thinking about that, or the parents, this child needs to go on with her life and not have a permanent ostomy, and we will move forward and we will manage things accordingly. And that's the conversation that we have.
What do you tell? There was a question that came in from the patients before this webinar. can a J pouch last a lifetime?
A J pouch, I hope could last a lifetime. That would
Yeah,
be
for
up to
sure.
my great surgical friends. But yes, this is the intent.
Yeah.
You know, we know that, I mean, realistically, joking aside, a pouch is not a cure for Crohn's or ulcerative colitis. So we're clear on that. We all know that. Although,
Why?
well,
If it's clearly ulcerative colitis, pathologically confirmed, why do you say that?
because there's something called pouchitis. There's
I
something,
know all about
you know,
pouchitis.
I'm saying it's not a magic bullet. It's not
Yeah,
a magic bullet is what I'm
but,
saying. They're not
you know,
symptom
all right,
free,
all right.
you know, it's,
I had too many fights with this at the GI conference on Fridays.
oh, okay.
But certainly we know that many patients who are diagnosed, as Joseph said earlier, with ulcerative colitis, even pathologically confirmed surgical pathology, develop some sort of a inflow limb problem or an pouch anal anastomotic problem. But the majority do not, if it's a confirmed diagnosis of ulcerative colitis. So I think J pouches are curative 90% of the time for ulcerative colitis, not indeterminate colitis. All right.
Yeah,
Does anybody have anything really that they want to add, because we're approaching the bewitching time?
yeah,
Joe?
I would just say the pouch requires care and attention, right? So even though we've got great outcomes, it's, you know, it's been an absolute revolution how to care for patients that require these surgeries. If we neglect it, that's where we can run into trouble. And so we want to make sure we take good care of the pouch.
How do you take good care of a pouch, Kimberly? How do you do that?
Feed it, you know, you make nice to your
The
pouch.
planet.
I'm not sure how, but yes.
Okay, listen, I enjoyed this session. I hope you did, and I hope our audience did. And I just want to thank you all for participating. And I'm sorry if I rushed through this a little bit, but this is always the problem with this. And particularly with three of you here, all very knowledgeable, it was not easy to be the moderator. So I appreciate it very, very much. Thanks very much. We're going to leave the meeting now. Thank you.
Thank you.
Thank you all.